Yeah.
And calcium, high calcium is one of the 13 reasons why abnormal labs can produce psychosis. And so we just took her off her calcium. Guess what? Psychosis went away. Problem
Wow.
solved. You know,
Wow.
that's why we got to look deeper and harder at
Yeah.
what's causing these symptoms and not just assume it's some mental deficiency of our patients. It's not. It's a physiological issue in a lot of these cases, especially when you have a sudden onset. But however, you take genetic issues and you know about the MTHFR gene, you know
Yeah.
about the COMT gene, you know about all these different genes. And if they do not have the ability to process folic acid effectively, they can't convert it to methylfolate, and then they can't
Hmm.
get it across the blood-brain barrier. And if they can't do that, they're missing norepinephrine, dopamine, serotonin, and melatonin, and they have issues with anxiety and depression and mood stability and sleep.
Welcome to the Functional Edge. I'm Dr. Julia Ward, and this is where science meets real-world strategies for living healthier, sharper, and stronger. From uncovering hidden environmental toxins to unlocking peak performance and mental clarity, we cover it all. Ready to take control of your health and thrive? Let's dive in. Well, thank you so much for taking the time to do this. I really can't tell you how appreciative I am of this.
Well, I love doing these kind of things. We've had our discussions with Dr. Ron for quite a while, and I do a lot of these Zoom meetings and podcasts and stuff like that. So this is just enjoyable.
That's great. That's great. Okay. Well, I guess we should just kind of jump right in. So your work integrates advanced methods like quantitative EEG analysis, neurofeedback, and photobiomodulation. Can you explain how these approaches work individually and together to optimize brain performance?
Sure, it's it's been a long road to get to the point where I am in understanding what's causing people's issues, and we just recently submitted a paper to Clinical EEG and Neuroscience Journal about a pattern we found, an EEG biomarker, we think, for neuroinflammation. Neuroinflammation is a tough cookie because even the most invasive methods for determining, such as spinal taps, still have a 15% false negative rate. So you can't really rule it out if it comes back negative. The only true way to do it is biopsy, and nobody's going to let you drill a hole in their brain in order to see if their brain's inflamed. However,
No.
I've got a doctor at Baylor who inserts electrodes into people's brains for intractable epilepsy. And I said, and those, he inserts 40 electrodes. And I said, and you extract those electrodes at some time? He said, yeah. I said, and they come out with brain matter on them? He said, yes. I said, I've got a study we can do. If you can just 40 of those, we'll do that. He does pre and post EEG, so we could determine if we got that biomarker. So neuroinflammation underlies so many people's anxiety, panic attacks, and this is something we haven't been addressing even in the neurofeedback field. We've known about this pattern and thought it was an EEG phenotype, but now I think it's really related to neuroinflammation. The reason I say that is because I do a lot of brain injury patients with two different centers throughout the country, not counting mine. And the prevalence rate in the general population of my study of 1,233 only was 30%. The prevalence rate in the traumatic brain injury population for litigation cases, these are going to court, so they're solid cases, is 80%. So, and then the locations in the temporal lobe tell me that the bony projections inside the skull are in the temporal lobe, and that is where you're going to get the bruising. So that's where you're going to get the more inflammation. So it's statistically we proved it. So it's something we've submitted. But I think this is a big breakthrough because what really works well on reducing inflammation? Well, hyperbaric oxygen, your specialty, photobiomodulation, mine. They both work on the mitochondria health to improve the health and increase the microvoltage, the actual power coming out of the brain. And so this allows for us for being able to actually determine the intensity of it. We can rate it and then watch it go down over time. And then when we combine this with neurofeedback, it's almost like a magical combination: reduce the inflammation and rewire the brain. So That's how they two go together, and whether it's photobiomodulation or hyperbaric oxygen or all three, counting neurofeedback, I think it's the wave of the future.
Yeah, that's great. Have you done any work with or used methylene blue in your practice along with the photobiomodulation?
I have not.
Okay.
I've heard of it, but I haven't integrated that yet. I do carry the orthomolecular product, so it's not outside my area to integrate something else. There's this product called KB220 that I did a study on when I was in Bahrain, setting up a program for the American Mission Hospital there, and saw a tremendous change in within an hour of administration, um, positive change, which we did publish. And so the blue may be the next wave, but I like to study it more and see. I like to test anything. What does it do to the brain?
Yeah, yeah.
So if
That's
you've got some cases you want to work with on me, I'm game for that. Let's do
okay.
it.
Okay. So with all these, range of tools at your disposal, how do you tailor treatments or treatment plans for patients with complex neurological or psychiatric conditions?
Well, that's the drive that I've had for the past 20 years, is really trying to figure out what's causing the underlying the symptoms that we presented with. I don't care what we call it. I think it's most important that we get to the source of where the problems are. And I do this with a wide variety of methods, including I always ask for anybody's most current labs. Those are critical. And you as a psychiatrist know that sometimes I feel that we're treating physiological issues that can be determined on abnormal labs with psychiatric medications, and it just doesn't work. And so this is why we really need to be focused on what's causing a person's issues. And I think that in the long run, um, the treatment planning that's done is very important to take into consideration the whole individual, their physiological functioning, their neurological functioning. Where are the abnormalities? Usually, when I do an EEG, and I've got two neurologists that epileptologists, board certified in epileptology and electroencephalography, we look for any indication of encephalopathy, which is just a abnormally brain issue, which can be from a toxin, could be from a metabolic issue, or can be from a hypoxic issue, as in those that we have with little children with tonsils and adenoids so large they're not getting enough oxygen to their brain at night. Mm-hmm. So all of these things we need to look at first. So when I look at an individual, what I'm looking for is what's causing the problems. Here's the presenting issues. Okay, and let's go down the path first. Let's rule out medical etiology, which is required by the DSM before we make a diagnosis. We have to rule out medical etiology cause, and then the next thing I look at is the medications are on, because as we know, as most people I get into my practice referred in are on polypharmacy. They've tried one, tried two, tried three. They're usually on 3 or 4 medications. It's not working, and nobody ever thinks to study why isn't it working. And this is what I've dedicated the last 10 years of my research to, is trying to figure out why medications fail. And I think that's a very important part. So when I'm setting up a treatment plan for somebody, it's specific to that individual, what we find, what the neurologists say about the EEG. Is it above the neck or is it below the neck? We can determine that in the EEG. It's kind of cool. So we need to start looking that direction. So when I get in a case, I don't know where we're going with it until I look at the EEG, until we get our reports back. And then we can go from that point and tailor it to specifically to the individual. And sometimes we hold everything up, especially in the regard of an encephalopathy. Well, we got to figure out what's causing the brain not to be able to be supported by the body. And we go chase those rabbits.
And can we just describe for people who don't know, like what exactly is a quantitative EEG? What does that look like, and what kind of information can you get from that?
Well, people make a big deal in my industry about QEEG, quantitative EEG. And what that is you take the data you collect from the EEG, you digitize it, and then you run it against a normative database, and you get how many standard deviations from the mean does it appear. And that is the fallacies. I did a whole study on the yabuts of because people are making a big deal about this. And I tell them, if you don't see it in the raw EEG, it doesn't exist in the brain maps. Look at all this beta we have in the temporal lobes, they say, and all this betas. What that is about is muscle tension, jaw tension from maybe gritting their teeth at night, or we have all this delta in the frontal lobes. Again, that's probably just eye movement, but you can't look at the brain maps and take them at face value if you don't know how to look at the patterns in the EEG and say, yes, there it is. I can quantify it now. So basically the best part of the QEEG is between treatments. I start this treatment, I finish this treatment, I do another brain map. Now we can quantitatively see how it's changed, but it's without the raw EEG, without the pattern recognition, it's absolutely worthless. And all these automated systems that are out there that do this for doctors, and there's a lot of automated systems out there, they're automatically artifacted, that auto-artifacting, meaning they strip everything but the background signal out. But in the case of isolated epileptiform discharges, which is seizure activity, it's isolated and it would be averaged out or isolated out. So you'd never know that the major problem you got with that brain is that it's misfiring in this one spot that you need to be looking at. And if it's severe enough and the behavior is matched, you need an anticonvulsant. So that's why I say everybody's making a big deal about QEEG, and I like brain mapping, but it has its limited purpose if you don't understand what the original issues are in the EEG that we need to be looking at.
Right, right. And so when somebody comes in for a brain map, they're getting like a skull cap put on with electrode gel through it, and it's tracing the brain, the electrical activity, kind of like, right, check it on the EKG on your heart.
Exactly. It's an EKG of the brain, and right, it's pretty consistent, but it gives us a lot of information. And there's only a limited number of EEG abnormalities that neurology will report. I'm actually doing studies for one neurologist because he found out of my skill sets, and then he's signing off on it. So, I just love to look at these EEGs and see what's sticking out, what's abnormal. And so this is the most important thing. It's an easy procedure. It takes about an hour from the time they sit down till they walk out. And I do what we call a routine EEG, which is 10 minutes, which is 20 minutes of collected data split between eyes open and eyes closed, as artifact-free as possible. So I do 11 or 12 minutes. Sometimes on kids, I have to do 15 to get some good data. And then that is the minimum that we need in order to fit that diagnostic EEG collection, which is a 95816 CPT code, and put it in as a routine EEG. Now, longer EEGs, 24, 72-hour EEGs, definitely can reveal more. The sleep-deprived EEGs can reveal more. But I feel like when I'm looking at an EEG, if I've only got 22 to 25 minutes of collected data and I see something abnormal popping up in it, then it's serious enough to consider medication like an anticonvulsant if it's seizure activity. So it's kind of like a screening tool that we don't want to over prescribe medications, and we don't want to under prescribe either, but we at least need to target it.
Got it. So what types of conditions are best suited for the methodologies you employ? Are there specific disorders or symptoms that respond exceptionally well?
Well, brain injury obviously is one of the big areas, because when part of the brain is injured, that part slows down and disconnects itself from the rest of the functioning of the brain. Mm-hmm. And you've got to speed that back up to tie it in and make it functional again. The brain wants to heal itself. It wants to reprogram, and it will. If you get passionate after a brain injury about something, that brain is sitting there just really waiting to be rewired. And I think that's where my high school concussions that took me out of college my first semester and sent me to Vietnam instead really paid off, because when I got into the military, I got passionate about certain things. And I think that's when the imprinting happened, and I got it excellent from the person who had no executive functioning skills to the outstanding executive functioning skills I was taught in the military. It's just the way the brain is. It's ready for the programming, and we need to take advantage of that opportunity when the brain has been injured, or we've had a stroke. I do a lot of work with stroke people right now. I do a
Mm-hmm.
lot of work with autistic spectrum disorder. I think that's a wonderful population. In fact, I think our greatest miraculous healings have occurred, if that's what you want to call it, on these nonverbal
Mm-hmm.
autistic spectrum children. My gosh, when in 6 weeks I can start a kid from no language to asking me how my day went, it just blows my mind. I'm just freaked out. Of
Yeah.
course, you get people with traditional ADHD, and they're pretty sharp anyway, but they just you're not going to see much change. But when you see somebody coming from a very far away from healthy to a
Yeah.
very functional state, it makes a big difference in everybody's lives.
That's awesome. That's awesome. On average, how long do patients undergo treatment, and how soon do they typically start noticing improvements?
Well, that's a big deal. I base everything I do on my success rate. I mean, I want to be successful, so I don't start everybody into neurofeedback treatment, for instance. I may have to hold up and say, I think something's up with this guy's gut and send him to functional medicine docs, which I love those guys. Those are wonderful doctors to work with. And then they go chase down gut issues or they go chase down toxic issues. And I'm not an MD, I can't order that stuff, but these guys will work with me and
Mm-hmm.
they chase it down. So that's the phenomenal part about that. The uh the sessions it takes are individual, but here's what I do. I tell everybody, we're going to schedule 40 sessions of neurofeedback, whether it's intensive in 2 weeks and do double sessions 5 days a week, or whether it's 2 times a week minimum for 10 weeks to get us 20 sessions, and then we'll reevaluate, do another what I call a mini Q. It's about half the cost, and it's a good way to determine where I need to set the next set of protocols and see what we've changed. I really love big electrical change, but that's because I'm a scientist. It doesn't matter. What matters the most is I'm improving the life of the person that's coming in. And I've seen tiny little electrical change and great gains by the
Mm-hmm.
individual. I've seen great gains on the electrical activity and very little change in the individual. I usually tell them it's between 5 and 10 sessions, you should be able to be saying you notice something different. Most people notice something different within the first five. By session 20, if we've got absolutely no gains made, we've missed something. We've
Okay.
missed a toxin, we missed something in there. Something is preventing this from responding normally. And I did a 76-year-old female sent to me by her Dr. Baxter Montgomery. He's an excellent cardiologist. And he sent her to me, and within 10 sessions, no, 20 sessions, we did intensive work 5 days a week for 2 weeks. We doubled her output on her microvoltage. So the power coming out of her mitochondria had doubled, and she had increased a cycle per second, which gives her about 5 more years of cognitive functioning before she goes back into the state where she was. And then I did this 73-year-old retired urologist, and we did the same thing with him, and he actually went backwards.
Oh.
And it's like, oh no, this is not supposed to happen. I'm usually seeing it go the opposite direction. And so to him, who's going back up to Chicago and going to Rush, I got some ideas. I think we've missed lead poisoning because in Chicago, 1984 was the first year that they stopped putting in lead pipes.
Mm-hmm.
And he's been in the same house since 1970.
Oh,
And so it's got all the old stuff. And if we don't get the lead out, we can't fix the brain. And so
yes.
I think that nobody's ever tested him for lead poisoning, as all his family's got Alzheimer's and dementia big time, which lead
Yep.
toxicity can do that. So it's just like, I really think this is what it is. We've missed something. And,
Yeah.
I would love to have my biggest gripe right now with the medical industry and with insurance is that it won't pay for functional medicine testing. They
Yep.
won't pay for toxicology. They won't pay for gut testing. And I think
Yep.
this is atrocious especially on refractory cases that failed multiple attempts of medication. We need to be testing for that. We need to be seeing what could be causing these symptoms and don't just think it's a failing of this personality of this individual.
Right. Yeah, exactly. Exactly. Do the tests that we know are effective and will give us the information we need.
Correct.
So, what metrics or feedback do you use to measure the success of a treatment plan? Is it just the behavioral outcomes, or are you measuring the EEG periodically?
Yeah, I do every 20 sessions. I do take an opportunity to measure and see where we were, where we got. And statistically, I can see if we've improved or not in the electrical activity. And I do a questionnaire that I send out. It's a 296 question questionnaire on the internet based so that they can do it at home. And it covers 46 different neural diagnostic categories. And it comes about printed out as this beautiful set of brain maps based on their answers. So I've got to line up the brain maps with the electrical brain maps with the brain maps I get from their answers. And when they line up, I've got a target I can go after. For instance, you wouldn't want to, if I went into a novice neurofeedback practitioner, they did a QEEG on me, EEG, they would find out this the left posterior temporal lobe is really messed up. Well, it's old head injury from multiple concussions playing football in high school. It's always going to look atypical. I shouldn't be able to speak. I shouldn't be able to write. I'm a published author. I'm a public speaker. Don't touch that part of my brain. It's wired around it. It looks atypical, but it's totally functional. So that's the most important part. Let's don't treat something that's been maybe rewired atypically and it's totally functional. So that's why I say I've got to match the person's brain maps that they create compared to my electrical maps. And when the two have something we can work on, I can go there. There's about 6% of the population that is actually reversed hemisphere, so language is on the opposite side of their brain. Not good. Don't do preset protocols and thinking because they have language issue, it's on the left. 4 to 6% of the time, it's on the right.
Yeah.
Have to know this.
Right. Right.
And so with that questionnaire, I'm able to determine which side of the brain has language. And that's an important piece. So if the reverse hemisphere, it changes everything.
That's great. That's great. Can you share any particularly notable case studies or outcomes?
Sure. We had this one case last year. I love these case studies because I got tons of them. 6-year-old boy referred to me from his therapist because she knew the work I did. He got kicked out of 2 kindergartens, biting kids, biting teachers. He was a little rabid dog. And the onset came in, like when they first started with him, but it got worse and worse. And so they sent him to me. I said, please let me take a look at his brain before you put him on an antipsychotic. So they sent him to me. I did the EEG and it came back with diffuse encephalopathy, possibly toxic, metabolic, or hypoxic. So I got this wonderful pediatric neurologist called Melissa Jones, which you probably know.
Yes, yes.
And Melissa's, because of me, she says, she blames me for getting her to be an integrative pediatric neurologist because she took 2 years more training after I came up with some of this stuff. She said, that wasn't in my training.
Yeah.
And so I sent her to him and I said, I really think it's a toxin, Melissa. It's just this, the look of it reminds me of something very toxic. And I had the spindling excessive beta, which is our, tool for either toxic issues or metabolic issues. And so she ran the test. She called me up and she said, well, Ron, we've got an abnormal amount of bad gut bacteria. But what's most interesting is we have toxic levels of Roundup in his brain, the weed killer.
The glyphosate. Yeah. Yeah.
So they spray this on their backyards to keep their backyards nice and clean. And the kids go out there barefooted. Well, the biggest pores on the body are in the soles of the feet, sucked it up in this kid's brain, and he couldn't chelate it out.
Wow.
So he was toxic. What would have been the treatment? And I'm asking you from your perspective, he comes in, you put him on an antipsychotic. What do you do next? If you hadn't done a good assessment of the toxicity levels in this kid, he would have been, the treatment would have been terrible. He'd probably have been in jail by the time he hit high school.
He would have been toxic on the psych meds in addition to the glyphosate, and he would have been just getting worse. And then you'd be managing one symptom with another medication and then another medication, and it would have
Totally true. Totally true.
Yeah.
15% of children have encephalopathy in my big study of 1,233. I had another case, 2 little boys, totally ADHD, little skinny kids, one 6-year-old, one 8-year-old. The 8-year-old's parents had tried him on a stimulant and it had terrible reaction. The other mother that was a 6-year-old, the mother of the 6-year-old, had actually taken had seen me present in a conference, and she said, why don't we do the EEG before we put him on medications? I said, oh my God, that's a brilliant idea.
Yes. Yes.
So we looked
Yeah, I wish all psychiatrists would refer their pediatric patients to something
Before
like
they do
this.
that. Exactly. So I did the EEG. Both of them came back with encephalopathy, possibly metabolic, toxic, or hypoxic. And so I got a checklist I go through because I know the questions to ask and I ask questions, and both of them seem to have sleep issues. And so I sent both these kids off to a sleep lab to rule out chronic obstructive sleep apnea. And sure enough, they were both only satting at night at about 92 or 90%.
Mm,
And that was preventing the normal maturation of their brain. So the reason they were acting so young and had such ADHD symptoms was because they're not getting good quality sleep at night. And so I sent them off to this one endocrinologist. What do you call those docs that do the ear, nose, and throat, ENTs?
yeah, yeah,
And he removed their tonsils and adenoids, and I did 3 months follow up, and their brains had sped up to normal speed in 3 months. ADHD symptoms going away. You can't treat chronic obstructive sleep apnea from tonsils and adenoids with a stimulant.
right. Yeah, yeah, that's not going to work.
It's not going to work. But were they correctly diagnosed with ADHD? Yes. The collection of symptoms we used to diagnose correctly identified the ADHD, but not the source of what was causing their problem.
Yeah, yeah.
And I had one child that I found with Hashimoto's thyroiditis, that
Oh,
same pattern. It
yeah,
was in the family. They hadn't checked it. The kid had it. You need to get your thyroid supported. You don't need to be on a psychiatric medication.
yeah.
And so I had this, I do studies for about 30 centers throughout the country. And I got this one study in of a 63-year-old female that went psychotic. Well, I spent 4 years, 3 months in a day in a psychiatric hospital as a running the psych unit. And you just don't go nuts at 63 years old. It doesn't
Yeah.
happen.
Yeah.
And so I said, and I looked at the EEG, and it wasn't quite encephalopathy, but something was off. And I said, "Can you give me a copy of her blood work?" She said, "Yeah." I said, as extensive as you can." And she did. And it came back with high calcium, osteoporosis, she couldn't process it. Her enzymes in her liver weren't quite right for it. And so she was on super high doses for her, able to process calcium.
Yeah.
She became, and calcium, high calcium is one of the 13 reasons why abnormal labs can produce psychosis. And so we just took her off her calcium. Guess what? Psychosis went away. Problem
Wow.
solved. You know,
Wow.
that's why we got to look deeper and harder at
Yeah.
what's causing these symptoms and not just assume it's some mental deficiency of our patients. It's not. It's a physiological issue in a lot of these cases, especially when you have a sudden onset. But however, you take genetic issues, and you know about the MTHFR gene, you know
Yeah.
about the COMT gene, you know about all these different genes. And if they do not have the ability to process folic acid effectively, they can't convert it to methylfolate, and then they can't
Hmm.
get it across the blood-brain barrier. And if they can't do that, they're missing norepinephrine, dopamine, serotonin, and melatonin, and they have issues with anxiety and depression and uh, mood stability and sleep.
Yeah.
That's a classic person right there. That's why you
Right.
guys, when you came up with starting with Deplin, was so genius. Yes, let's get that into their system because they can use that for this specific gene that affects about 30% of the population out there.
Yes. Yes, it does.
And
That's
so those are
amazing. Yeah. Go ahead.
the cases just go on and on over the past 20 years that I've come across. And we had a lady, 55-year-old female, that presented to me with over a 3-month period. She started dropping things, had word finding issues, had balance issues, had headaches coming on, and had lost the ability to sing. She sings beautifully. And so I said, that's interesting. So we did the study, and it came back with this really unique pattern called TMSSA, temporal minor slow and sharp activity, most likely correlated with cerebral vascular insufficiency. Okay, that makes sense. So we had an MRI done, and the MRI came back negative, and then the neurologist wanted to send her for conversion testing. You know how they are. And I said, no, I know this person personally. It's not that. I need an MRA. I want to see the vascular system of her brain, not just the imaging.
Right.
I had to go through 4 neurologists before they finally, one of them said, okay, Ron, we'll do an MRA.
Uh-huh.
And if we find something, we'll do a paper on it. And I think he was just humoring me because he was a friend of my sailing buddies. And so we did that and he came back and he said, Ron, we have to get your patient in the hospital, St. Luke's, within the next 2 or 3 days. Looks like she's got a 7 millimeter aneurysm in the paraclinoid area right behind her left eye, right where I said it would be. And it's turned out to be a 9 millimeter fusiform aneurysm. They've never seen one on anything but autopsy. And she was within months of rupturing, and she would have been dead in 3 minutes. And
Wow.
they went in through the femoral artery all the way up behind her left eye and put a stent in, 3 coils, and another stent to hold in place and killed it. I have repeated this thing multiple times with different patients. But a reason I got so committed to this is that patient was my wife. So she is
Oh,
still alive
wow.
today because I wouldn't let it go that this abnormal finding in the EEG was
Yeah.
related to cerebral vascular issues. I've got a good friend of mine that is a sailing buddy, and he came in with the same dizziness, vertigo, lack of energy, everything else. And I said, and we came up with the finding TMSSA. And I
Mm-hmm.
told him 2 years ago, I said, it has got to be either the pump, which is the heart, the vessels going to the brain, or it's got to be in the brain. And he said, well, my heart's good. I just had an EKG and everything else. I said, okay. So he went all through the neurology route. The neurology poo-pooed on what I said about that insufficiency. And even though it's in the literature, we've got the studies, it's cited and everything else. But the biggest complaint I have with medical doctors, pardon me for saying this,
That's all right.
is that they stop reading research when they get out of med school.
Yeah.
And if you're not today, research is just fast, growing, growing, growing. If you're not there reading it almost weekly, you're missing it.
Yeah.
So I get a picture from him the day before Thanksgiving. He's in the hospital. And so finally, he browbeat a cardiologist into doing a PET stress test, a chemical stress test.
Mm-hmm.
He had 90% blockage.
Oh,
They go in and do 2 stents in his heart, open him back up, and guess what? Symptoms are all going away. It has to be the heart, the vessels going to the brain, or it has to be in the brain. And so the vessels going to the brain, I was doing a presentation at the brain injury conference for a bunch of attorneys, and I found out something really phenomenal from a bunch of chiropractors. This one particular chiropractor there was really good. Do you know that in accidents, major vehicle accidents, when you get whiplash, there's a curvature in the neck called lordosis, and that can be straightened in a severe whiplash.
yeah.
And as the rubber band stretches, it gets skinnier.
Yeah.
As the carotid arteries stretch, they get skinnier, and you reduce your blood flow to the brain. Chiropractors can put this lordosis back in, but there's a DMX, uh, digital motor X-ray. It stands for, and they actually do this live X-ray and show that entire thing, and they can come up and diagnose this and put the curvature back in. Pretty phenomenal. But it can count for all these people who have accidents, and then they're having balance issues and memory issues, and they're fainting, and I mean, it's just amazing how this stuff
Yeah.
is connected. But it has to do with blood flow to the brain. It either has to be the pump, the vessels going to the brain, or the brain. And we've never missed yet in that diagnosis with coming up with where we can go to help a person with these atypical issues that have a sudden onset.
Yeah.
You know, I was
Yeah.
this way before the wreck, and after the wreck, I'm this way.
Yeah.
Okay, we've got a
That's
situation.
Yeah, that's fascinating. So, do any of the treatments you offer, the quantitative EEG, the neurofeedback, do you get insurance covering any of these procedures?
Well, in the state of Texas, they've identified three, well, in the federal government, in the FDA, they've identified 3 areas of intervention that should be covered, which is substance abuse disorder, which is considered a head injury, traumatic brain injury, and ADHD. The 3 things that should be covered by insurance. In the state of Texas in 2009, they passed House Bill 1919 that told every insurance company from the state of Texas, it couldn't be Blue Cross Blue Shield of Louisiana, But from the state of Texas, they could not exclude neurofeedback for the treatment of brain injury, acquired brain injury, anything after death, including stroke, traumatic brain injury, including substance abuse. And guess what? Unless you fight them and take them to the damn, excuse me, take them to the court and try to, get the court to make them do their job, they're going to deny, complete denial on what's supposed to be covered, even though ADHD, it's head abuse, substance abuse, and brain injury should be covered by the research that's out there. They're still not covering it. I'm so frustrated with insurance right now. This is the big bone I have to pick with them right now, because I'm not going to take insurance because it's not worth my fight. And then to find every other reason why you look at what happened to the CEO of United. From denying a bunch of claims of somebody, there's a whole group of people very angry, as you can see, about the way the healthcare company does this. And it's people that are totally not medical doctors in a lot of cases denying these claims. And that's wrong. That's totally wrong. You as a psychiatrist, you need to be able to say what your patient needs, not some goofball that's hired by them. Their job is to keep from paying claims.
Right. And just to remind you, I'm not a psychiatrist. I'm a functional medicine doctor. Sorry.
I'm sorry. I thought you were.
No.
Well, I think you're one of the best functional medicine doctors I know.
Thank you. So yeah, it is frustrating when there's a treatment that's very non-invasive and that's non-pharmacologic and effective, so effective, and yet they're just denying it because, they'll make up whatever reason, but it's,
Well, here's what I'm working on right now. The World Psychiatry, which is the journal, which is the top psychiatry journal in the world, came out with a paper in 2022 and said that in the past 50 years, they did a meta-analysis of all the meta-analysis, and they found that psychiatric medication does not work, either does psychological interventions work. They're just not efficacious. Big paper that was written. And so when this paper was written, and they say we need a paradigm change. Well, this was my impetus to present why we need to be doing EEGs on all of those cases that failed multiple attempts of medication, or refractory cases, because we identified there's only 4 reasons for all medication failure. And it's one of my 4, which is one encephalopathy, isolated epileptiform discharges, the spindling excessive beta, which is inflammation, and the focal slowing, which could be brain injury or some abnormal fold or something. And so at that point in time, I was going through some cancer treatment myself, and I was not happy with my MD Anderson cancer doc, who was an MD, PhD, brilliant man, at explaining my abnormal labs. I brought him a body that had perfect labs. He put me through chemo and radiation, come out on the other side, my labs are totally messed up.
Right.
But he didn't. He just blew off a bunch of the stuff. And so I got a research team, and I said, okay, team, here's what I want you to do. Look up every abnormal high and every abnormal low lab you can find. Tell me what the physical symptoms are, the psychological presentation, the likely causes, and the appropriate MD referral. And so we built this table. It took about a year to get this thing built. And we're still working on different things like toxicology and psychiatric medications, because psychiatric medications are supposed to be doing annual labs on anticonvulsants, antipsychotics, lithium, and all the substance abuse drugs. But they're not doing it. And if they do it, what do they know? Which organ messed up which lab because of their medication they're using? We know Risperdal, the antipsychotic, men have gynecomastia, boys start growing boobs. Not cool, but most everybody knows about that one, but not the rest of the drugs. And so they put this together for me, and I'm putting together a program right now. And I got the website, and I got the I've got the URL, explainmylabs.com, because we're going to be offering this to any doc that wants to enter this in, or any patient that wants to enter this in. All your highs and all your lows, hit enter, pay a small fee, and it'll come out presented with this information. If we can get this into LabCorp or Quest, it will be great, because then it puts it back to the patient that says, okay, here's the likely causes of your abnormal labs. Here's the likely doctor you need to talk to about it, because right now the different specialties aren't talking to each other.
Yeah.
You're stuck. I want functional medicine docs like you to be funded by insurance, because it's totally nuts that they do not fund you guys and they won't pay for functional medicine testing. Once they get the original testing done, that's all they'll pay for. And that's ridiculous. You guys are the best in the world out there for determining what's causing a person's symptoms and how to treat it. So I think, and that's my soapbox I like to get on right now. So I'm working with machine learning, artificial intelligence right now to make this program super.
Yeah.
So, and then we're going to collect all the data and put it out there for open access for research, de-identified data, because we're collecting hair color, eye color, culture, gender, everything that we need to do to allow people to, when we get the large data sets coming in there, that data is going to be available for research purposes.
Yeah. Oh, that would be great. That sounds really great.
So,
your personal experiences with traumatic brain injury and PTSD seem to have deeply influenced your work. How do these experiences, how have they shaped your approach to treatment and research?
well, being a Vietnam veteran, firefighter for 20 years, a commercial diver, all this stuff has led me down a path that's different from most people because I don't look at anything from a tight little eyeglasses like this. I'm looking at it broadly. And as a firefighter, I used to have to come into an unconscious person or an infant that couldn't talk to you, and within minutes come up with some way we could save this person's life. So that was my clue. What are the clues? Where are we in? What's the house look like? What, I'm constantly asking questions. What? What could explain this? And so that has really helped me look at this stuff differently. My background with physics, for instance, I love physics. I think it helps us so much in our field. Uh, Remember when Intuitive came out, the ADHD medication, non-stimulant medication for children? Well, Intuitive was an old guanfacine, which was not a very good blood pressure medication. But when it came out, I was at one of the drug rep meetings because I like going to those and drinking their nice wine and eating their good food.
Mhm.
And I'm usually the only PhD there because I'm the only one to mess with medication. And we had this presentation about this new alpha 2 agonist for ADHD. And so at the end of the presentation, this old pediatrician stood up and he said, I have one question. How do you get from a blood pressure medication in an adult to an ADHD medication for a child? And so the medical doctor got that presented, got up there and started talking about the chemistry and this alpha 2 agonist and everything else. He said, no, you don't understand my question. I need to be able to explain this to parents why a blood pressure medication for an adult is now medication for a child
Right.
with ADHD. And so this other, I call them baby doctors, these newly doctored residents that just got out of medical school or something. He got
Yeah.
up there, took off on a similar course, and he shut him down. And Tiffany's, I don't know if you know Tiffany, one of the drug reps, and she said, well, we'll talk to our medical director and we'll try to get you an answer. I said, Tiffany, I might have a thought on that. If we consider that we've been told for years that ADHD is a problem with poor perfusion to the frontal lobes, poor blood flow in the frontal lobes in a certain subset, and that if we know Boyle's law of pressure, the inverse relationship between pressure and volume, that if we have poor perfusion, we have lower volume, which means we have higher pressure. If we put a blood pressure medication on, it's going to vasodilate the frontal lobes and bring in more blood volume, which is going to lower the pressure. And I think that's why it works. He said, good answer. I said, I don't have a clue if that's what they were thinking, but it's something that makes logical sense to me. Fast forward to December 2 years ago, a paper came out for COVID brain fog. The only medication that they came up with to treat COVID brain fog, which is neuroinflammation, and they said neuroinflammation is guanfacine plus NAC. I was justified. We were right. We've been doing it since 2009, and it seemed to work on this pattern, but I had no clue that this was inflammation. I just thought it worked on this pattern. So
Yeah.
that's where my brain goes because I've got this history, buried history across all these different jobs that I've done. And you've got to understand physics if you understand the functioning of the brain with blood flow. My wife's aneurysm, the reason we had the problem is because of this eddy effect. Because if you throw in the periclinoid area, you got the carotid artery is about that as big as my little finger. And you've got this blood flowing at high pressure and it hits those three lobes. It creates an eddy effect downstream, like you're crimping a garden hose, and it makes the downstream temporal lobes have all these issues.
Yeah.
again, it's physics. It's just the way flow dynamics are. And I think that's one thing that the doctors don't have is in regard to putting all this stuff together, you have to understand a lot of different things. And physics has been my biggest advantage because if it's a law of physics, it has to apply to everything from an atom to a universe. And so let's make sure we're staying within the law of physics and understand why the person's having these issues. Sometimes it's flow, sometimes it's incompatibility with the genes missing in the individual. We just don't. There's so many things that can cause these issues. But that's where I want most, and I'm trying to teach that right now. Teach them how to be investigators and not just quit with, well, that medication doesn't work. Well, why doesn't that medication work? It's supposed to be. The EEG is a homeostatic regulatory system that's supposed to bring you back to neutral once you're bounced out for whatever stressor you're under. And if it doesn't, something's wrong. There's something wrong in this system. Could be the MTHFR gene. You don't have the foundation materials to make your dopamine, serotonin, melatonin, and norepinephrine. But it's a fun time. I enjoy doing what I'm doing. My wife says I'll retire noon the day I die. I just love what I do, and I love every cases. So if you got any cases that are out there driving people crazy, between you and me as functional medicine docs are the best in the world to work with because they want to get to the root of the problem. And I'll get a lot of referrals from functional medicine docs now that say, we couldn't figure it out, so it's got to be in the brain. My cardiologist sent me this case the other day, final case. And this lady was having totally runaway blood pressure. I mean, even when she lay down, it went even higher. She was in 200 over 180 blood pressure. She's about ready to stroke out. He said, I can't find it, Dr. Ron. I said, I did everything I could. I can't figure out why I can't control this woman's blood pressure. It's got to be in the brain. Okay, let me look at it. And so we did an EEG, and sure enough, in the posterior part of the brain, we found what we call intermittent rhythmic delta activity. And delta means it's subcortical, getting down to the brainstem. And it turns out being a very treatable encephalopathy that if you don't know it, they die. if you figure it out, it's easily treatable. It's one that you can treat. It's very treatable encephalopathy. And so I sent him back over to him, and he did his research and everything and altered what he needed to do. And the lady's no longer a patient of ours. She's got her blood pressure under control. But again, functional medicine docs, when they run down their whole rabbit hole of whatever they figured out, and they don't figure it out, maybe in the brain, and I can help them. And I'm always referring out to them because I'm not a medical doctor. I can't go chasing toxins down. I can't go chasing gut issues down. I can't order that stuff. But that's
Dr. Ron, can you move a little to your right? Because the sun,
the sun. Okay.
The sun was glaring, and there we go. Yeah, it was just like, it was too much. There we go.
Better. Thank you. I didn't even see that.
Yeah, thank you. Well, okay, finally, what advancements or innovations in neuroscience are you most excited about? And how do you see the field evolving in the next decade?
Well, I'm really excited about the combination of treatments. I think combining treatments is the way to go.
Yeah.
The three things that I'm really excited about, neurofeedback, obviously, photobiomodulation, and hyperbaric oxygen. Hyperbaric oxygen has got such an advantage, and it does the whole body. Photobiomodulation, I can just do the head because I can't do the whole body. And I recently have put together a team with my, I wrote a paper in 2019, published in 2021, about treating severe brain injury with hyperbaric oxygen and neurofeedback. And my colleague in Bahrain sent me an article quoting me. I love those articles about treating with using hyperbaric oxygen and neurofeedback. And so they always have a corresponding author. So I wrote the author and I said, I really like what you're doing here. I appreciate you quoting me. I'm trying to put together a team. So he wrote me back, love to do it. So about a month ago, I developed this, what we call neurobaric research network. And my hyperbaric oxygen guy from Bahrain, the American Mission Hospital, and this treatment facility that has two locations outside of Detroit called Oxford Center. And they have one place that has 70,000 square feet. They've got 8 chambers running all the time.
Nice.
And they got a second facility. Wow. And then my team that I work with in Virginia, the hyperbaric treats tier one operators. We're talking about the knuckle draggers, the door kickers, the military hardcore, SEAL Team 6 and all those guys. And they're really a great center out there. And then I contacted my buddy in Bahrain, and we brought this group together. So now we're calling it the Neurobaric Research Network. And now I've got an opportunity to expand our research. We're trying to coordinate our research, so we're doing it from multi-sites, combining hyperbaric oxygen with neurofeedback. When I was in Bahrain, we were able to get the issues solved in order to get the penetrators through to put our electrodes inside the chamber to read the brains and run everything from the outside. So we did the first ever 2-atmosphere dive during hyperbaric oxygen in Bahrain. And so what a great thing that was, is that, let me find you a picture. You got to see this picture. And there she is in a hyperbaric chamber at 2 atmospheres doing neurofeedback.
Oh, that's great.
So we got that worked out. Got the equipment to do it. And so we're trying to do, what a perfect opportunity to, while they're at pressure, to do neurofeedback.
I love it. You're knocking out 2 therapies at once.
Why not? They're doing nothing for an hour.
Yeah, yeah.
You might as well be training the brain, and we did air breaks every so many minutes, and it's just, so we're working this. So now my thing is, if we can get, I think we can, with this guy I just met the other day, thanks to Michael Pierce, another one of the functional medicine gurus.
Yeah.
He put me together with this guy, and it looks like we may be able to get a large grant to run this multi-center study on doing this. And working with Seacrest Chambers, and that's chamber he had, and I got a connection with them. So I'm trying to set up right now a hyperbaric research and treatment center here at the Med Center, because we really need to be doing this from a large scale study here in Houston. You've got your operation. That's why I really love working with you. You're close. You're at least in Sugar Land. There's another person way up in the Woodlands that has a hyperbaric center, but we need to be bringing all these people together in order to try to do this, because it makes so much sense. And if we can get a twofer out of it and combine these therapies, especially if we overlap on top of that photobiomodulation, which they could take, buy the equipment themselves and do every day, we've got really a chance to make big changes in people that are really suffering right now, whether it be head injury, whether it be stroke. My colleague that I'm working with right now, we've been trying for 2 years to get hyperbaric oxygen study done with the soft chambers, because that's all we could afford. We've got 2 soft chambers on chronic pain study and a dementia study. Now, if we can get that chronic pain study done and publish that to get people off of opioids using hyperbaric oxygen, you know where that's going to set us on the map?
That's huge.
Wonderful stuff right there. So Dr. Miguel Popola is his name, and he's over there next to NRG Stadium, but very brilliant. He's had several NIH grants and stuff like this, but we're having a hard time getting the IRB approval for soft chambers, because, there's just not much interest in doing that. But I love the hard chambers. I just can't afford them. Now maybe we can get something worked out with Seacrest and do hard chambers. But that's where I think the future is going. The photobiomodulation, the cycle, and the hyperbaric oxygen to treat the neuroinflammation piece and heal the body. And then put a stack on top of that, the neurofeedback to reprogram the brain, to rewire the problems that have been disconnected from the head injuries or the strokes or whatever. I think it's just going to be a phenomenal thing to kick off.
Yeah.
And hopefully that's where I'm going with the next years that I have to try to get that to happen.
Oh, that sounds so exciting. Well, I really appreciate your time and sharing all this wealth of information. It's been fantastic. And I look forward to speaking with you again soon.
I love that. And I would love to come out and see your center and see your chambers. I just, as a commercial diver, I started in this area back in the early 70s. And I've ran more offshore operations for saturation diving, but, regular decompression diving and everything else. So my history in hyperbaric oxygen has always been something I've really loved. But now to think we're going to be doing research in that area is just fantastic. So I think you're onto something. And I think your functional medicine work is absolutely wonderful. Anybody that comes in must know that you're not satisfied until you figure it out. And that's the
Yeah.
most important part. We have to
Yeah.
figure out what's causing these symptoms.
Yeah, exactly. Cool. Well, I'm going to stop the recording here.
Okay.
Thank you for joining me on The Functional Edge. I hope today's episode gave you fresh insights and practical tools to level up your life. If you found value in what you heard, don't forget to hit subscribe, share the podcast with someone who needs it, and leave a review. It's the best way to support our mission of bringing powerful health solutions to more people. For more resources, updates, and behind-the-scenes content, visit drjuliaward.com. Until next time, stay strong, stay healthy, and keep living on the functional edge.